to be a lot of problems going on there. And so your number one priority is almost always going to be safety with both depression and bipolar, because of the risk for, with depression and suicidality, but with bipolar, when they're in a manic phase, of course, for the impulsivity that's going to occur. It's okay to set personal boundaries with these patients. This is going to be something that would be relevant to a test question you might see, is that if they are inappropriate with you, it's okay for you to set a boundary and be like, I'm sorry, that's not appropriate for you to talk to me like that. I am your nurse. So just like, remember in our episode that we saw with the bipolar individual who was telling the nurse, and she said, I know that you want to have sex with me too. I can tell by the way you're looking at me. And the nurse was like, I'm your nurse. I do not want to have sex with you. This is not appropriate behavior. And so they redirected the behavior, right? Yeah. So if you see an answer like that, that's appropriate to do. Also, remember that they are going to have some very unstable behaviors, such as rapidly shifting moods, agitation, rapid speech, and they may even hallucinate. The big thing is that behavioral instability, unstable behaviors may happen during a manic phase. So here again, what is your priority with these patients? Safety first, then sleep, eating, and hydration kind of all are on the same level for the next, right? Because if you don't get that patient to sleep, they're not going to get any better, and they could be in serious trouble if they're not eating and drinking. And so these things are big deals, right? Okay. So there you go. So typically when you're treating a depressed patient, you're going to add an antidepressant, like an SSRI. And when you're treating with somebody with bipolar, you're typically going to also add in a mood stabilizer, or you may use lithium because it does both, right? So, okay, let's go on to the next one. No, it's not letting me. For whatever reason. There it goes. Okay. Suicide screening is always on the exams. Now that you've covered the topic, it will be in some format on every exam. I don't remember if this was like primary to this test or not, but there are several suicide screening questions on there. Remember, of course, that in depression and bipolar disorder, there is a really high risk for suicide. And so I think they say as many as 20% of bipolar individuals die by suicide. And I want to say 50% or more attempt suicide. So anyway, there is a high risk for suicide in depressive and bipolar patients, and of course in the geriatric population. We talked about that. But remember, when it comes to geriatric populations, it is not a normal part of the aging process. But it does happen more frequently because of the life stressors that occur, and all of that during the geriatric period. Remember the elements of the suicide screening. Go back to your CSSR, right? What do you assess for when you're looking at suicide? You're looking at previous attempts. You're looking at, whether or not they have a plan, whether or not they have access to that plan. Like if they tell you my plan is that maybe I could go and, what was it? Somebody told me one day, it was like really goofy. They wanted to go to San Francisco and jump off the Golden Gate Bridge, which for most people, they're not going to get on a plane, fly to San Francisco and jump off a Golden Gate Bridge to commit suicide. However, with this individual, she actually did go to San Francisco for that purpose. So for her, it was a feasible plan. But for most people, because it's not easily accessible, something would stop them, because you have to have a lot of intention to go from Oklahoma to California to jump off a bridge. So anyway, whether or not there was a previous attempt, if they've actually had an attempt, like they've tried to cut themselves, they've tried to hang themselves, something like that, not a thought, not a thought of it, not a previous plan, not talking about it, but if they've actually had a previous attempt, that is a huge risk factor. Presence of a plan, especially a plan that's easily accessible, intent to follow through. Now, so like if you were a 10-year-old kid and there are no firearms in the house and you have no access to weapons, and you said, I could get a gun and shoot myself, because there's no access, that's probably not as dangerous for that child, right? So it'd be a little bit lower suicide risk, but it is really lethal, so you still worry about it. But at the same time, it's different from a guy that says, I have a 38 in my nightstand drawer and I could use it right now because it's already loaded. That's a lot more access there. So that's what we mean by that. And the intent to follow through on it. How much do they actually intend to commit suicide? Have they been writing notes? All of that. What shows you their level of intent? And what are their protective factors? Like, do they say, I believe that, it's a wrong thing to do. I have my children to live for. All of those things are all parts of what we assess. So when we're looking for suicide screening, review that CSSR and make sure that you know what you're assessing for on there and what the elements are that are included in the suicide screening. Due to the risk, if you have a suicidal patient, safety is your number one priority unless they're like literally coding on you. I mean, pretty much that's your ABC. So psych is safety, and observation is a critical part of that. You cannot leave them alone. You can modify the environment and reduce the risk, but you still have to stay with that patient under surveillance of some sort. So what would you need to do when you're sending a patient home post-discharge? This is a real question. What would be important measures for you to take when you're sending that patient home?
Reassess suicidal ideation.
That's one, yes. Yes, Taylor.
Do you live alone?
Why would you ask that?
See what their social situation is like, if they have someone to turn to, or I guess I wouldn't ask, do you live alone? It would be more like, if you start, who are you going to call if you start feeling this way again?
Like the suicide contract. Yeah, I agree. Okay. Like the suicide plan, or what do you call it? Safety plan. So. Mm-hmm. All right. What else would be on there when you're sending a suicidal patient home? What if their plan was to kill themselves with a gun?
See if they have any weapons.
And what would you do with them if they do?
Get rid of them? Like have them get rid of them or give them to someone they trust?
Yeah. Have them get rid of them or give them to someone they trust or something. If they plan to overdose on their medication, if they have somebody else at home, you might have that person distribute their meds to them. So my point of it is your priority intervention when you're sending a suicide patient home is a suicidal patient home is if they have a plan that it has a lot of access, you want to block that access and you want to create a safety plan for what they're going to do. Okay. No harm contracts are great for discharge. And once the client starts to improve, it may indicate a need for the reduction of the level of observation. So say that you're 2 days into treatment, you and your patient work to complete a suicide safety plan. What happens to your level of observation then when they've agreed and they've completed the safety plan? Or done a no suicide contract with you? Okay, I agree, I'm not going to hurt myself. What do you do then? You might reduce the observation level, right? If they're like arm's reach and then they decide that they're going to make a contract with you, you might decrease the observation level somewhat depending upon the patient assessment. Because we are in a modified hospital environment, so there's not a lot of access for them. Okay, here's another thing about observation. 1-to-1, or at least line of sight in a modified environment is necessary if they are actively suicidal and unable to agree to safety. So if I have a patient come to my unit, we never have anybody on 1-to-1 unless, like that guy last weekend that was running into the walls, he was 1-to-1 because of the fact that he was actually arm's reach, which we almost never do. But that was because he was actively trying to harm himself in front of us. Most patients, though, who are suicidal will either be 1-to-1 observation, which means if they go to the bathroom, somebody goes with them. And for the most of the time, they just sit in the day area with the other patients and interact. But because they're on 1-to-1, we have to make sure they're not doing anything. But we realize it's probably not going to be something where they're going to be running into the walls that could immediately hurt them, like right in front of us. The other part is the 15, the line of sight here again, the 1-to-1 is like one staff member assigned to one patient. And then if it's a line of sight, that means that they're just kind of like within the unit and we go to the bathroom with them. So most of the time in a modified environment, this line of sight is adequate for an adult patient. But, obviously if you have somebody that's banging their heads into the wall, then it has to go to one within arm's reach. So, all right. So remember that once that patient's able to agree to safety, though, you might decrease that to 15-minute rounding because you do have a modified environment based upon, your assessment of the patient. Anyway, the other thing to remember is the suicidal thoughts that a patient has can absolutely overwhelm them. And so, the thoughts that they're having can be very difficult to deal with. And so if we can start to, what'll happen is you'll have a patient who just everything in their life is going wrong. And so they don't know how to start to even get better. And so it's kind of like that old adage, how do you eat an elephant one bite at a time? What you start to do as a nurse is to start to bring out one thing and to work on one thing. Okay, so let's talk about one thing. And then you can start that process of gradually taking one thing and one thing and one thing until they have a plan at the end of it. Does that make sense? Okay, because there's a question kind of related to that. So basically, these thoughts can overwhelm a patient, and helping them break down problems into more manageable parts can help begin that task of healing. It doesn't make things better overnight, but it can help. Okay. All right, just for review, I do know that there is a question to one of these items on there. Body dysmorphic disorder. Usually there's something that's going on with them that's not actually that bad. Like, for example, somebody may not like how close their eyes are set together or something like that. But these individuals become so obsessed with it that they'll go to great lengths to hide or change it. And plastic surgeons do see these people a lot because they're full of these patients. And so just remember with body dysmorphic disorder, that's kind of that, unnatural obsession with a part of the body or, their appearance in general. And they check the mirror a lot. They, they don't believe they look good enough until they fix it, all of that. So hoarding, I don't think we really need to explain that because I know we've all seen that show, right? Hoarding is, it relieves anxiety by bringing in, not difficulty, not getting rid of stuff. It causes incredible anxiety to get rid of things. And then excoriation disorder, that's the one that's seen frequently in, methamphetamine users because they pick at their skin. And that has to do usually with IV meth use because there are toxins in there I think they're trying to pick out or something. So anyway, they have usually big sores in their skin. So also the trichotillomania, the pulling out of the hair. Okay. Now, when it comes to somatoform disorder, answer questions. I've seen this in several places on several different tests, and I know it appears on this one in some form. You know that they're getting better when they're not as focused on the physical symptoms. So if you're looking for the right answer on a question, if you have several options and one of them shows that they're not very physically focused, then you're like they're actually showing some insight into, hey, I see that, this actually gets worse when I'm anxious. And when they start to make that connection, that's a really good sign. So that's the answer you're looking for. So look for the answer where they're not so focused on their physical anymore. And when they're recognizing their symptoms are not just physical, but actually a manifestation of their psychological distress. And of course, we can help this process by, therapeutically with communication, exploring the underlying cause of the patient's, distress. So obviously, if a patient is in our unit and they ask us for pain medication, what we're going to do in that instance is go get the pain medication. If the pain medication is due, give the pain medication. Then use that as an opportunity to sit down and talk to the patient about what's been going on over the last few minutes that maybe caused their anxiety to get up, so they needed the pain medication. But the first thing we want to do is make them comfortable before they're able to process that, right? So if we sit down and we try to process with our patient first, and we try to say to him, okay, you want pain medication, tell me what's been going on that led up to this. How willing are they going to be able to do that at that point?
Probably
You
not.
think they're going to be very willing to do that? No. But once we meet their need, do you think they're then going to want to sit down and talk to us about what made it get worse? Yeah, okay. So that's a good thing, right? So if a patient complains of pain, give them the med, then you can emotionally process with them. You meet their need, and then you talk. So when it comes to somatic symptom disorder, remember one of the diagnostic criteria of that is most of the symptoms are all encompassing. Like you might say, my toe hurts, my liver hurts, my heart hurts. So basically there are all these systems that are not really related most of the time. And when it comes to this, they often believe it's a medical problem, not a psychological problem. So you're not going to usually see them in the psychiatric unit because what they are, they're like, no, I don't have that. I have a stomach problem. But the reality of it is that their anxiety is expressing itself in their somatic symptoms, right? So a good example of this is my somatic symptom disorder patient presented, and has multiple digestive issues, multiple issues going on. She had spent probably, and the medical people were great because they tried to find a physical cause. And finally, it was because she couldn't express her depression culturally. So she came into our unit and the depression started getting better and her somatic symptoms started going away. So that's a good example of, how sometimes if you don't have the words and you can't talk about it and you can't get your anxiety or your depression out there, then it just eats you from the inside out in some ways. It's like it kept manifesting itself in these somatic symptoms. Now, I do want you to know, though, that people with somatization of symptoms sometimes really have legitimate problems. So if you're asked a question on your boards, if you're asked a question that says a patient with somatic symptom disorder comes in complaining of this or this, you are going to rule out the medical first as a priority. Because do you think people with somatic symptom disorder have heart attacks?
Yes.
Yes. Yeah, and what tends to happen is when you have a psychiatric underlying disorder, it's frequent that you'll see these people get sidelined when they come to the ER into psych. And I have seen a few patients that have shown up on my unit who are not really psych, but are medical. And we wonder, we're like, why did you send them over? Well, they have a diagnosis of schizophrenia. That doesn't matter. You should have ruled this out. This is actually going on. And so we send them back. So I've done that many times. They don't like us. Okay. All right. So now we'll go on to illness anxiety disorder. The big thing is not like somatic disorder where you're really focused on those symptoms. You're more focused on the idea that you have something wrong. So you may attribute small symptoms that you have to very dire consequences. And so these people either are care avoiders or care seekers, right? They're attributing those small symptoms to the fact that they could have this horrible disease. So like you get a bump on your hand and you're convinced it's cancer, something like that. So, okay. So despite the fact that you suspect somatoform, as I said, always rule out the medical. And don't forget about conversion disorder, and that's those pesky major symptoms like blindness. If I went blind, I would be totally freaked out. But these people are not. It's that labelle indifference because they don't care because they're getting their anxiety reduced. So once they experience blindness, their anxiety goes down. They get better and the symptoms of that patient get better when they can begin to identify the trigger of the anxiety. So once the patient can start to actually process it, those symptoms will go away. And remember, you can have paralysis, you can have blindness. If I went suddenly paralyzed on one side, I would be freaked out. I would think I was having a stroke or something. But these individuals, because it's relieving their anxiety, they're totally not concerned about it. So, and then remember, dissociative identity disorder is usually a protective personality due to abuse that person suffered as a child. So abuse is the primary cause of that, right? Okay. Let's see, sleep. All right. So remember, when you're assessing sleep, the biggest factor in assessing sleep is how do you feel? Oops, hold on, it's going backwards. Here, no, that's not it either. One more. Yeah, let me see if I can get this back to where it's supposed to be. There it is. Okay, let me try to reshare this with you now. All right. So there you guys go. All right, back to sleep. Okay. So the biggest factor in sleep is how do you feel? I mean, if you feel rested, it's like maybe you're getting 5 or 6 hours a night and you feel rested after 5 or 6 hours, that may not be that big of a deal for that particular individual. Now, obviously, if we're getting down into 4 and 3, that probably is. But, if somebody tells you I'm getting 6 hours of sleep a night, but I feel great, I don't feel tired during the day, then that's a big factor. So the question is, what do you assess in sleep? And remember, the factors you assess is the quality of the sleep. How well are you sleeping? How do you feel? Do you feel rested the next morning? How long does it take you to fall asleep? I think that's called sleep latency, isn't it? How long does it take you to go back to sleep once you've woken up? How many times a night do you wake up? All of these are important things to assess, right? So we also are looking for bad patterns. And this is what you guys did. So you should remember this really well. Remember those sleep assessment questions. You were looking for bad patterns. What were you looking for?
If we ate like right before bed.
Yep. What else?
Our caffeine intake.
Caffeine. What else?
If we took naps.
What else?
Different things that we would do in bed other than sleeping.
Yep. What else? Alcohol consumption. Why is alcohol bad? Doesn't give you the good sleep. It's funny because alcohol is like notorious for putting people to sleep, but it messes with their sleep architecture. So that's why it's not a good choice for like people to actually use to sleep, because it does mess with their sleep architecture. So that's interesting. Okay, so when we're assessing sleep, we're not only looking at quality, perception, how long to fall asleep, how long to resume sleeping, nighttime awakenings, but we're looking for bad patterns that are occurring. And so what's wrong with taking a nap? Why is that not a good form of sleep? Does anybody remember? What does it not have that a longer term sleep has that you need?
Yeah.
It has that good sleep architecture, right? The in and out of the different phases. So those take quite a little while to actually, go in and out. So when you're talking about shift workers who, if you're a napper and you're doing okay at night and you're taking a 30-minute nap in the afternoon, probably not a huge deal. But if you're somebody who is using the naps to try to substitute for sleep you didn't get somewhere else, it messes with your sleep architecture quite a bit. So the structure of the sleep is different when you're taking a nap versus when you're actually sleeping. The other thing is what happens if somebody's not getting good sleep? So if you find out that somebody's working the night shift, they're getting 3 hours a day, they're taking a couple of naps, and they're not getting that sleep architecture, and they're tired all the time, what are the dangers of sleep deprivation? What would you warn them about?
Falling asleep while driving.
Falling asleep while driving. That is how a lot of accidents occur. What else?
Or decision making.
Yeah, you might do something stupid. Yeah. What else? Concentration, right? Okay. But the big one is probably the driving, because that can kill you pretty quick. So, okay. All right. Let's go on to the next one. Like I said, this is just a broad overview of like these topics, but it's based upon what will actually be on the test. So, okay. All right, now we're looking at grief and loss. Remember that many grieving individuals will experience survivor's guilt, which is feeling, gosh darn it, swear, I keep losing my page. Okay, hold on, let me get back to my slides. See, this is why I don't like to do things on my laptop, because it's so old It like has serious issues. Hold on, let me go back. Okay, come on. Do it. There we go. Okay, there's sleep again. Okay. Well, now I'm back to somatoform disorder. That's not working. Okay. There we go. Grieving. Okay. All right. Hopefully this stays on that page and doesn't go flying off somewhere else. Okay. So when it comes to grieving, remember that many grieving individuals will experience that survival skill, which is, even ones who aren't in like some big accident or something might experience some guilty feelings like, it should have been me, or I should have been able to do something for this person so that they didn't wind up, didn't die. If I had only gone sooner. You may remember my story of Johnny, which is the patient that I had that was experiencing some pretty depressive symptoms, and he came to the ER and he thought that he was having a heart attack, and then he wound up in the psych unit trying to harm himself. And when he and I finally sat down and talked, he told me about how his wife had become septic, and it had so affected his life to the point that he had cognitively pretty much shut down and become very delusional because he was so depressed. Okay, let's go back to there. All right. So anyway, when it comes to the grieving thing, do you remember that can happen? Hold on. I swear this laptop is horrible. Okay. I really need a new laptop. Okay. When it comes to types of grief and loss, try to know the difference between at least these. Anticipatory is when you have a person who's sick for a long time and the family's expecting the death. Disenfranchised is when it's a type of loss where you're not socially allowed to grieve. Like, for example, an abortion or maybe a miscarriage or a big high profile where you're on the opposite side. Like Ted Bundy's mother, she would not have been expected to grieve, right? So ambiguous loss, where you're not really sure that there's actually a loss, like a missing child or a missing in action veteran. And then also remember, complicated grief is when there's an over-response due to previous ungrieved losses. So like, you may have had your parents die, but then you had to go ahead and be strong because you had to get back to work, you had to take care of kids, all of that. And so you didn't grieve the loss. And so later on, you hit a squirrel on the road and it just devastates you. That could be an example of like a complicated grief. Okay, and remember characteristics of specific populations with regards to grief. Like single moms may experience a lot of pressure to return to work. Men tend to be pressured to return to work. Men may intellectualize grief, whereas women, tend to better emotionally process it. Women have more social support than men do, and men tend to lack social support when they're grieving. And the societal norms of men and women in the grief expression is that men are expected to be strong. And so these things can lead to some problems with the grieving process, right? Okay. So I would definitely know the characteristics of those groups and be able to tell the different types of loss apart, for sure. Okay. I've got the spinning wheel of death. Right before COVID happened, I don't know, I had this feeling I needed to update my computer. So I went out and bought this really nice new Mac desktop. So every day when I see you guys, I do it on my nice new Mac desktop, but sometimes I have to get on my Mac laptop, which is like 1 billion years old, and it just doesn't work that well. So sorry. Maybe I should update my laptop too, but those Macs are expensive. Okay. All right, hang on, let's see if I can get to the next slide. There it is, the meds. Okay. Don't forget that when a patient is started on a new antidepressant, These are the things you need to remember. You know, of course, there are those side effects later on that I want you to remember in practice, but most of those are common for a lot of different meds, like the, nausea, vomiting. That's almost every med you can take. But one thing you need to remember is that they're going to have an increased energy level at 2 weeks, but they're not going to have a mood improvement until 3 to 4 weeks. So this is going to increase their suicide risk quite a bit. So you need to alert a family member if it's a suicidal patient. They need to be watching during that, 2 to 4 week period when you have the energy, but you don't have the mood improvement. And so that's a critical point in time when you're going to be watching that patient for that. It's important to tell family members if you have a patient that's inpatient, it would be very important to watch them during this time to make sure that they're not at increased risk of suicide. It would be important for you to tell your patient this. It would also be that they may have an increase in suicidality from the very get-go. I've had patients who literally have come into the unit before and told me, I was really depressed, so I started on this antidepressant, but I don't know why, but I've never had suicidal thoughts before, and now I'm having suicidal thoughts. For whatever reason, some patients do have that as a side effect of this medication. A lot of bipolar individuals will initially present with depression. So be sure to tell your patient to watch for manic swings in their mood. These are all important teaching points, okay? Another important teaching point is that it can cause dizziness. So be sure and encourage them to take fluids and to rise slowly to reduce orthostatic hypotension. Because if they suddenly jump up and they're all just starting on an antidepressant, they may all of a sudden go boom and hit the floor, right? Did you know that? This is funny. I do tell, it's not funny, but I do tell my patients this. I have this whole routine that I do when I'm teaching about fall precautions. And one of those is I sit up there and I'm like, okay, did you know that if you learn to hang onto your chair when you stand up, it may save your life? Because if you're over 50, 60 years old and you fall and you break a hip, like over 60 years old, that is a life-ending event for more than half of the people who actually fall and break a hip. So if you're over 60 and you fall and break a hip, half of them will die within 1 year. And so it may save your life if you learn to put this into practice now. So anyway, we have a nice little talk about orthostatic hypotension and how the meds can cause that and how we don't want to break a hip. I don't want to have to send anybody to the ER today because that's a bad day for everybody. So, it's pretty funny when I do it. But anyway. All right. So also here's the other thing I really want you guys to know, because class of medication is a mess. MAOIs are almost never used because they react with almost everything. They actually react with like all kinds of foods, all kinds of other meds. So if you're putting a patient on an MAOI, you are going to get a really lengthy list of everything that they should avoid. You're going to give that to them. You're going to find out every single supplement they could possibly be on because of possible interactions. And if you look on all kinds of other meds, it'll say cannot be taken with an MAOI, cannot be taken with an MAOI. Look it up sometime because they're like all these meds you cannot take with an MAOI. So we hardly give them anymore. So if you have a patient, who thinks they should start taking one or, whatever, then make sure that, they go through their physician and look at every single med there is before they start on something like that. So the other thing I want you to remember about meds is lithium. So when you think about lithium, think about kidneys and thyroid and monitoring. And then the other big points of lithium are, hydration and leveling out the sodium. So you're worried about the kidneys and the thyroids, you're going to be monitoring the level of the lithium because of the narrow therapeutic range. And the part of maintaining what they need to maintain on the lithium, maintaining that blood level, is going to be staying hydrated, avoiding activities which are going to dehydrate them, or making sure they drink extra fluid during that period, and leveling out the sodium. And most of you guys did your little drug care plan on that, so most of you already understand that. So, okay, so these are the big picture of what you need to know about the meds, okay? So I realize that this is very broad, and when you take the test, you'll understand why I've included the things I've included. And hopefully it'll help you answer some of the questions. If I could just help each one of you get another extra 2 questions right, On the test, by the test review, it's been worth it, right? Okay. Questions about any of this? Is there any of this that you didn't understand?
Are we gonna have to know like certain anti-epileptics, or are you just, is it gonna be broad question like anti-epileptics are used?
You know, I don't even think that they're actually on this exam, but I do want you to understand that they can actually be mood stabilizers. And so I went ahead and put it on there because I know that there's a possibility it could be on the final, but I don't think that there are any anti-epileptic questions on this exam. So, but valproic acid, a lot of those can be used. So I just wanted to be sure that you knew, that it could be a mood stabilizer. When it comes to bipolar, you're always going to treat the depression, but you're also going to treat the manic, potential. And so some of the things that you're going to use for that are, of course, lithium will act for both, but frequently you'll see the anti-epileptics, like you'll see somebody on Depakote and an SSRI, or you may see somebody on an antipsychotic. There's some really good antipsychotics that work for actually depression and for mood stabilization. So you might see someone on, like Abilify is a big one that they put a lot of bipolar patients on. So, but we aren't covering antipsychotics until next week, so it won't be on the exam at all. Any other questions? I really want you guys to pay a lot of attention to how you answer therapeutic communication questions on this exam, because there are a lot of, even though we're covering topics that are related to depression, you're going to need to actually, think through and figure out what the right answer is based upon therapeutic communication. Now, what I've given you today is a broad overview of some principles that you need to follow, like when you're talking about depression and you have a patient that is talking about, whether it's a delusional versus a self-esteem issue, that might be important for you to differentiate, to kind of come up with a nursing diagnosis or something like that. But always pick the therapeutic answer. Does that make sense? Look for the therapeutic answer. So hopefully I've given you enough information to do that. I feel like I'm speaking in code or something here. I'm trying to give you what you need without telling you the question. So I do feel like I'm trying to speak in code, but hopefully it'll all make sense when you get to the exam. You'll be like, oh, Professor Stanley said that. Yeah. So, any other questions? If I were going to concentrate my studies on the biggest part of the exam, depression and bipolar are by far the largest part of the exam, because I feel like those are major, major concepts. When it comes to depression and bipolar, here again, manic symptoms versus vegetative symptoms, how to recognize, how to treat, how to assess, how to establish priorities for those. So that, to me, that's the most important thing. So, when I went through and I picked out questions for this exam, I think exam 3, Dr. Cook technically put together last year, and then I just revised and dropped a bunch of questions I didn't like. But this is the vast majority of the test. And then after that, grief is going to have probably 3 or 4 questions on it, 3, 4, 5 questions maybe. Antidepressants and mood stabilizers are probably 3 or 4 or 5 questions. Somatic symptom disorder, maybe 4 or 5 questions. Other disorder, maybe 4, 5, 6 questions. And then depression and bipolar are probably going to comprise about 25 of them. So if I were going to really concentrate my study efforts, I would focus on depression and bipolar disorder. And then I would study the PowerPoint, and like the things I've said in the PowerPoint, just kind of have a good, understanding of the things we've talked about. You guys need this PowerPoint? Would it help you to focus your study efforts?
Yes, I think so.
Okay, what I'll do is I'll share the link with you email because it's on my like, oh, what do you call it? The little OneDrive thing. You know, the Google Docs. So, oh, I got a text message. Hold on. Somebody texted me. Chat. Okay. Hi, says yes. Okay, good. All right. So here again, you know, depression is a big part of it. I would definitely know depression pretty well. I would definitely know the bipolar. If any of you guys miss a question about geropsych and screening for depression and how it's not a normal part of the aging process, I am going to strangle you. No, I'm kidding. I said that so many times. If there's a question about it being a normal part of the aging, you better not miss it. So, all right. Any other questions? If you do miss it, when you come see me afterward for your test review, I'll be like, okay, you should have done that one. I won't even go over it. All right. Nobody else has any other questions?
Is there going to be a question on ECT?
There is not on this exam, so I wouldn't study it. If there is one, it would not be like a main question. It might be mentioned somewhere in another question, but it's not like the main topic, focal topic for sure. Yeah. I will try to put something on the final about ECT because I feel like it's something we spent a lot of time covering, and I feel like it would be appropriate. And for whatever reason, it didn't wind up on this test. I'm not even sure there exists a question about ECT therapy out there because Dr. Cook, you know, was, like I said, she used to go in when it was very dangerous still, and people would, you know, more like what you see in One Flew Over the Cuckoo's Nest. And so she, you know, wasn't on board with ECT. And so now that she knows more about it, it's, you know, she understands that it's a good thing. But back in the day, really the risk benefit wasn't there. So there weren't any questions about it when I came in. People didn't really understand it. And honestly, most site nurses don't ever see it. It's pretty rare that you have a site nurse that actually gets to see ECT and understands it pretty well. So most site nurses are still afraid of it. Other questions? I'm a little freaked out about ketamine therapy.
About
Anybody heard of that? Taylor, have you heard of that? Huh?
what therapy?
Yeah, you broke up.
I said I'm a little freaked out about ketamine therapy.
Oh, no, I've never heard of that.
Well, they're using the drug ketamine as an antidepressant therapy and for people who are having problems with pain too. But the problem with ketamine is I think there can be some permanent psychosis that results from it. So I'm a little freaked out about that.
Is it FDA approved?
No.
Oh.
Mm-mm.
But yeah, that's a red flag there then.
Yeah, but people are using it. It's like the new deal. So, yep. All right. Any other questions? Okay. And so what do you think? Let me ask you a question that'll help you, maybe help you answer this. In depression, why do you think partially individuals who are depressed, you know, very, very depressed, have difficulty thinking that they could change anything?
It depends. They might be in such a situation for one thing. Like if you're, especially if you're like a young person, maybe you live in a poor home or an abusive home.
And there are coaches that I've had that are in situations that are very difficult.
Mhm.
Yes.
But all things being equal, if we're talking like just on a pure psychological, biological basis, why? My guess would be the lack of the proper hormones in the brain that deal with independence. That would just be my educated guess.
And I agree that there is a lot to do with depression. There is that biological basis of serotonin, a lot of the hormones. But the other thing is if those chemicals are so depleted, they're not even giving you the energy to get out of bed. Why would you have the idea that somehow you could affect change? If you can't even get out of bed in the morning because you feel that bad, then how are you possibly going to it's going to get better. I'm going to change my life. I'm going to be able to do something to get better.
Well, and then, and then in that sense, from a very real perspective, they're right. That is true. Like if you have severe depression and it's not being treated, then objectively you cannot affect change any more than you can run a marathon on 2 broken legs. It can't be done.
Exactly. Yeah, exactly. And then remember too, probably part of this low self-esteem and this punishment and this guilt is that ongoing sense of, I can't even get out of bed. Other people are getting out of bed, feeling like a failure over and over and over and over. So while there's some of it biochemical, some of it is based upon what you've been able to do, what you haven't been able to do. And some of it's going to be based because a lot of these kids have these chemical issues. A lot of people have chemical issues because of what they've experienced through adverse childhood experiences. And so when you're experiencing adverse childhood experiences, those are usually not things that are going to build your self-esteem and make you feel good about yourself, are they? So there's a whole host of things that go into this vicious cycle of depression. So anyway, I thought that might help you to understand it a little bit better. But, all right, any other questions? Okay, well, hopefully I've given you enough information to answer some of what I would have considered the harder questions. I'll go ahead and I'll post this and send you guys a link on this through the email. And if you have any questions, feel free to call me about this. And everybody have my number. Feel free to call me before Saturday at 11 a.m. After that, I won't answer any questions. So, yeah. All right. I'll see you guys later. Bye.